Bismillah Rahman Rahim. I am Dr. Asim from Pathology Department. We will be discussing diabetes mellitus. The learning objectives of this lecture will be to learn about the basic facts about the diabetes mellitus, classification of diabetes mellitus, and the pathogenesis of type 1 and type 2 diabetes mellitus. And the most importantly, the diagnostic criteria of diabetes, and then the complications of diabetes mellitus. These things will be covered not in one lecture, in rather 2 or 3 lectures, because it is an important topic considering its prevalence, its complications. So, first of all, it is a clinical syndrome of heterogeneous origin characterized by an abnormally high plasma glucose level resulting from defects in insulin secretion, action, or both. It means we cannot say that it is a single disease. It is a rather syndrome because there may be involvement of many other organs due to the complications or due to the metabolic dysfunction. Approximately 11% of the population in Pakistan is affected by diabetes, and it is the leading cause of end-stage renal disease, which is another disaster for patients going for the dialysis. Second most common complication is the adult onset blindness and then non-traumatic lower extremity amputation. There was a survey about 10 years ago in which Pakistan in 1995 was having 3.6 million people affected with the diabetes. Later on, about 10 years later, it was estimated at about 14.5 million of Pakistani population will be affected in 2030. Now, in 2019, there is a survey by the WHO, and you can well imagine from here, Pakistan 19.4 million is having at this stage. It means the diabetes is increasing gradually day by day in our population. The prevalence of the complications in Pakistan, neuropathy is about 36%. And second most is the nephropathy and then retinopathy. All these complications due to the different causes, different pathogenesis, and particularly the main cause is the hyperglycemia. Who are more prone to have diabetes? If you look at the figure, then you see that the age above 65, family history, in which familial incidence and also the genetic component, then stress, obesity, high cholesterol level, hypertension, race, pregnancy, inactivity, certain medications, they can lead to the development of the diabetes. Let's see on this question. Mr. XY, 42 years old male, was referred to emergency department by general practitioner with complaints of the thirst and excessive urination for last 8 months. There is no relevant past history. First cousin has diabetes on insulin, on no regular medications. He is an obese man having BMI of about 26. Blood glucose random is 260 milligram. The random level should be less than 200. From this picture, what we can infer is what type of the diabetes does the Mr. XY have? There are many types of the diabetes, but particularly type 1 and type 2, we will be discussing in detail. According to this is a type 1, type 2 diabetes mellitus. What is the difference between these two types? Type 1 most commonly occurs in young age, and type 2 in the middle age, elderly. Normal BMI, not obese, but usually in the type 2, the patient is obese, overweight. Family history is usual in case of the diabetes mellitus. There is short duration of the symptoms in type 1. In this particular case, in type 2 mellitus, it may be for months or years, like you saw in this case, that having thirst and for the last 8 months, patient may ignore such type of the symptoms and actually he is having the diabetes. Diabetic coma can present in type 1 diabetes most commonly. In type 2 diabetes, it does not present with diabetic coma. There is definite requirement of the insulin in type 1, but there may not be any requirement in the early stages. If it is controlled properly, the insulin level may not be, insulin injections may not be required. This is a patient GL who was probably in December 15, 1922, was having this picture. And after the injection of the insulin, his health totally changed and he was living a normal life on insulin. It's just after 2 months of the time period. Now, coming on to the classification, broadly it is classified into two major categories. Although all forms of the diabetes are important and all forms are having basic abnormality of having hyperglycemia as a common feature. The underlying abnormalities in involvement of the development of the hyperglycemia, they vary widely according to the cause. The vast majority of the cases of the diabetes fall into two major types, that is the type 1 and type 2. In type 1, there is beta cell destruction, which leads to absolute insulin deficiency. Most commonly, it is immune-mediated or it may be idiopathic. The type 2 diabetes is a combination of insulin resistance and beta cell dysfunction. Insulin resistance is that where insulin is available but it cannot act. It cannot act to enhance the glucose uptake by the cell. It is a combination of the peripheral resistance to insulin action and inadequate secretory capacity and response by the pancreatic beta cells. 90 to 95% of the patients have type 2 diabetes mellitus, and vast majority of these cases are obese. There are other causes which fall in the category of the classification: genetic defects of beta cell function, maturity onset diabetes of the young, MODY, and then MODY having different types: hepatocyte nuclear factor, glucokinase, hepatocyte nuclear factor 1 alpha, then a lot of other. Then genetic defects in insulin action, type A insulin resistance, and lipotrophic diabetes, including mutation in the PPARG. These are the different types of the diabetes which are having the hyperglycemia, but the cause is different. Then exocrine pancreatic defects are important component of the classification, in which chronic pancreatitis, neoplasia, cystic fibrosis, hemochromatosis, and then other endocrinopathies like acromegaly, Cushing syndrome, hyperthyroidism, pheochromocytoma. These all cause hyperglycemia, and we have to differentiate it from the type 1 and type 2 because these are the secondary causes of the hyperglycemia. Then there may be infections like cytomegalovirus, Coxsackie B virus, congenital rubella. First, we discussed that it may be genetic, it may be due to some inherited or familial component. But if someone is having familial tendency, the infection with the cytomegalovirus or the Coxsackie B virus, they play as a secondary factor and environmental factors. The use of the drugs like glucocorticoids, thyroid hormones, and interferon alpha also lead to the development of the hyperglycemia, and we have to differentiate it from the different categories of the diabetes. Then genetic syndromes like Down syndrome, Klinefelter syndrome, these are the other causes of diabetes. The most important another topic is gestational diabetes mellitus, which is during the pregnancy. The diagnosis of the gestational diabetes mellitus is important because of the effect on both the fetus and the mother at the time of the delivery. So this is another different topic which we will discuss later. What is the pathogenesis of diabetes? As I said, genetic factors. It may develop in the childhood, but becomes manifested in the at puberty and progresses with age. Genetic susceptibility and environmental factors, which we discussed. And then there is a common presence of the HLA locus on chromosome 6p21 in diabetes. Then 95% of the Caucasians with this disease have either HLA-DR3 or HLA-DR4. This shows the association of the immunoleukocyte antigen number to the development of the diabetes mellitus. Then polymorphism in the gene associated with beta cell function and insulin secretion may be the pathogenic factors in development of the diabetes. Environmental factors like viral infections, mumps, rubella, Coxsackie B virus, and cytomegalovirus, they play a role. What is the mechanism? Viral infection induce islet cell injury and inflammation. It's just like the hepatitis B or C virus affects the hepatocytes and cause ultimately lead to the cirrhosis. Similarly, in this particular case, it may affect the pancreatic cells and lead to the destruction of the cells due to the viral infection. They produce proteins which mimic the beta cell antigen. By molecular mimicry, it means that there are these antigens which are produced, they replace or just counteract the action of the insulin action. So importance of this is that whenever there is a presence of the insulin, insulin can attack because these antigens have occupied the receptors. It might persist in the tissues of the interest and subsequent reinfection with the related virus. Supposingly, if a person is having some viral infection and another infection at some other time is there, patient may develop diabetes mellitus. Then there is failure of the self-tolerance in T cell. It means in our immune system, there is a defective clonal deletion of the self-reactive T cells in the thymus. The defects in the functions of the regulatory T cells leads to the defective clonal deletion of the self-reactive T cells in thymus, because the self-reactive T cells, they produce toxicity and damage to the pancreatic cells. In diabetes, the targets of the immune attack are three components. Number one is the insulin. Number two is the beta cell enzyme, which is called glutamic acid decarboxylase, and islet cell autoantigen B512. All these are the major factors, and antibodies against these are used to diagnose the different cause of the or the pathogenesis of the diabetes in immune-induced diabetes mellitus. If you look at the picture, if a person is having genetic predisposition, beta cell mass is there at the age of the 5 years, then avert immunologic abnormalities, but insulin release is normal. Mass is decreasing, insulin release is normal, then progressive loss of the insulin release, and still the glucose is normal, then becomes at the age of the 20 avert diabetes, in which mass is also reduced and there is loss of the insulin secretion, so there is no insulin to act on. What is the pathogenesis of type 2 diabetes mellitus? It is the mainly the insulin resistance, that which is decreased response of the peripheral tissues to insulin, or beta cell dysfunction, inadequate insulin secretion. Now, these two components, insulin resistance and insulin deficiency, are the key factors in the development of the diabetes mellitus. Sedentary lifestyle, dietary habits, obesity, and familial tendency. These are the factors which lead to the development in the type 2 diabetes, which is a common thing in our society at this moment. In environmental factors, sedentary lifestyle and dietary habits, as I said, then genetic predisposition, there is disease concordance rate of 35 to 60% in monozygotic twins compared with the nearly half that in the dizygotic twins. If both parents are affected, then their likelihood of developing the diabetes is more as compared to having one parent who is diabetic. Now, what is the role of the obesity? If you look at this obesity, that is the vasculature, adipocyte, and from here free fatty acids are released, then adipokines and inflammation. These factors lead to the development of the insulin resistance. These are the pancreatic islet cells, which are the beta cells, and then there is beta cell number increased because of the compensation. Here, insulin secretion by the beta cell is normal. Here it is increased. Here, blood glucose level is normal. It is normal to impaired glucose tolerance over here. But when beta cell failure is there, cells are damaged and cells are less in number, then there is decreased insulin secretion by the beta cell and development of the diabetes mellitus. It means the blood glucose level is increased. Insulin resistance is a very common topic and important in the sense that it is being measured by different parameters. Failure of the target tissues to respond normally to insulin. This is the basic flaw over here. The sensitivity of the insulin, the hepatocytes, is lost. It means the insulin action is not appropriate. Then there may be some functional defects. The functional defects may be due to some structural changes in the insulin. So these factors lead to the insulin resistance. Obesity and the insulin resistance have a very common incidence. Non-esterified fatty acids, fasting plasma levels of these are increased and insulin sensitivity is decreased. It means the obese persons are more prone to have insulin decreased insulin sensitivity. Now, if you see at the natural history of the type 2 diabetes, this is normal, this is pre-diabetes, this is type 2 diabetes. Pre-diabetes means that patient is not having that clear-cut levels of blood glucose which are labeled as diabetic, but he is more prone to have diabetes at a later stage. Fasting glucose level, if you see over here, and then after meal glucose level, insulin secretion, this is biphasic, then insulin resistance. If increasing insulin resistance is present, the glucose level will remain abnormal and high. So development of the diabetes and progression of the diabetes is also related with the insulin resistance because insulin is not acting upon. The obesity, which may be, obviously, which one would you like to have? Either this obesity or this obesity, pear-shaped or it's apple type. This is called central obesity. This is called peripheral obesity. It is more dangerous like this. This is the central obesity. Fat is accumulated in the belly, which is more dangerous as compared to the other one. Patient is more prone to have different types of the diseases like diabetes, hyperlipidemias, and hypertension and other abnormalities. This is the dietary change pattern. Here we have developed this one. We are standing on this. No walk, no regular exercise, junk food, and other factors, they are causing the incidence and the prevalence towards the increasing number. This is another example of this one. From here, you have to travel by on foot rather than you are driving and going to the car. The role of the adipokines in the diabetes is because these are pro-hyperglycemic adipokine resistant retinol binding proteins, then anti-hyperglycemic adipokines like leptin or adiponet. The deficiency of these may lead to the development of the diabetes. In obesity, there is definite deficiency of this one. The pro-inflammatory cytokines like tumor necrosis factor and interleukin 6, they also cause development of the diabetes in the and the play a role in the pathogenesis of diabetes mellitus. Then peroxisome proliferator activated receptor, nuclear receptor, it is also important, but they cannot be measured, but this is a tendency to detect this one. In the next lecture, we will discuss about the diagnosis and diagnostic criteria of diabetes mellitus. Thank you very much.